Good afternoon, one and all. James here. Thank you for joining me. Whether you're with me live or you're joining me on demand afterwards, thank you very much for being part of this. I really appreciate it. I'm going to take you through pretty much an hour of content, making sure that we're doing as much preparation as possible for R180 and for that January exam. If you're doing that exam in January, or perhaps you're looking at this after January and prepping for the summer, we really hope that what you're going to go through here is going to be really, really useful. It will be far better if you do the following things. Try to have available to you the notes pages we got for this session. You should be completing those as you follow along. Also, there is the National Mock Exam paper, mark scheme, and also model answers. Those resources together will prove to be a real strength of yours and a basis for you to go and succeed on this examination if you go and have a really good look through. For example, take my model answers and example mark them with the mark scheme, get to feel them and understand the language I'm using to pick up those marks, and so on and so on and so on. So it's a really nice opportunity for you to really sort of get ahead if you use those sort of things. Now, as I said, we expect the session to be around about an hour in total. I'm going to deliver some content to you along with the in line with the notes packs. Then we're going to do a little bit of Q&A in the middle, and then we'll go into the second half, and we will be definitely out of here by 6:15 this evening, unless of course you're taking this on demand, which it's then up to you, isn't it? Now then, before I start, can I please ask you if you would be so kind to hit a like on the YouTube stream. Do consider offering a sub on the channel as well. These are little things that you can do that can really help us to keep these sorts of provisions out there for you. So the more that you can do that, then the channel sort of gets boosted and has more impact. So if you could do that, we would really, really value it. Thank you very much. Now, without further ado, I'm going to get flying into... Oh, I thought I froze there for a second. I hope I didn't. I'm going to... this is always the sort of testing moment for me where I transition from one stream to the other. But here we go with sports injuries and dealing with common medical conditions. Let's hope this goes well. So here we go, my little R180 injuries and dealing with them, friends. It's not a term I've used before. Let's make it sort of a really strong start here. This is how I want you to work with this revision session. Obviously, you can use this however you wish, but what I would strongly recommend is that in your notepacks, which you really should have, you have a little read of these bullet points, and then you make sure you have these with you. Your notes pages should be what you are making your notes on. Hope if you haven't got those, they're just down below the session that you're watching right now, whether you're watching it live or on demand. You should also have your national mock, which I have written for you, your national mock exam. You should have the exam paper, the mark scheme, and the model answers that I've written. So that is a really great way to be prepping for your R180 exam, okay? Studying our exam paper, having a go at it, marking it, perhaps with support of your teacher, and looking closely at the model answers that I've provided, maybe even marking those model answers to see the sorts of language that is being picked up and how I'm structuring answers. That is what we'd be expecting you to do to really sort of maximise the impact of this, in association with looking closely and as often as possible applying anything that I talk about today, or write down the screen, applying it to Josh, to Tom, to Kate, to Laura, to Julie, to Carlos, to different kinds of sports performers, different kinds of people. And I'll try and do that throughout the session. These 6 examples here are to give you kind of like the nutrition of how to apply the learning and the revision that we're going to do here, and to give you an opportunity to actually go, okay, how would this work for this person, Kate the triathlete, or this person, Laura the gymnast, or this person, Carlos, the wheelchair basketball, etc., etc., etc. Okay, one final thing before we get into this. Notice the list that I've got here for you, okay? This list here is everything that was in the national mock exam. And notice there are things that are not highlighted here. Mental strategies, price, x-rays, for example. I'm not actually going to cover these in this particular session because it will overfill the session in essence. I'm going to cover extrinsic, intrinsic factors, aggression, components, I'm going to cover these parts of the course. But notice you can go and have a look at this, this, and this in the mock exam itself, even though I'm not going to cover it in this session. But of course, as you can notice here, we're doing whatever this is, 12, 14 different topic areas, cover it across the whole topic area range. And you can have a lot of confidence that you're covering a big chunk of knowledge here, but it's not the whole course. Let me be clear about this. It's not the whole course that we're covering here. It's sections that I have chosen, and of course you do need to make sure that you revise everything. That goes without saying. With all that said, let's jump in. We're going to have a look at extrinsic factors which influence the risk and severity of injury. So we're interested in what are the risks and What is the likely severity of injury? And how do those factors that come from external environments, external factors, how do they influence things? Well, the first one is what we call types of sporting activity. What do we mean by this? Well, first of all, different sporting activities influence the tendency to become injured. Let's look at a few examples. Let's look at rugby, and I'll just put a dotted line here. It can lead, on occasion, types of rugby can lead to things like concussion. Now, we can manage that, right? Because we can play maybe touch rugby or tag rugby, for example. We could be talking about, if I put gymnastics here, we could be talking here about Laura, as my example, gymnastics. Someone might experience something like a heavy landing and might experience sort of like or numerous heavy landings, and might experience of overuse injuries and impact injuries, for example. We could be talking about someone who is doing mountain biking. What would you say is the likely injuries of someone who's doing mountain biking? And you'll probably say, well, the chances are they could be talking about falls. This could lead to fractures. Okay, there could also be concussion. I'll tend to wear a helmet, of course. We could be talking about netball. This was, who's my performer, Julie, and we could be talking here about muscle strain, or it could be something like ligament damage from all the twisting and the turning that is done. These are factors that are these are factors which they relate to the actual activity themselves, and they could sort of influence the risk of certain injuries, and also how likely they are to be severe. Would we expect sort of a muscle strain to be a severe injury from netball? No. But if someone falls very, very, very heavily from a mountain bike on a very fast descent, for example, then a fracture could be really, really serious and severe. Now, other factors, instructing and leading influences as well. So let me just change colour here. Excuse me. What about the following? What about our coach's knowledge of technique? Okay, so if our coach is, let's say, coaching us trampolining, and they really understand the technique, we're likely to be safer, right? Injuries less likely. What about their experience? Have they done this before, the coach or the instructor? What about, for example, how they communicate health and safety? These are factors, let's stick with my trampoline example, having spotters that are correctly positioned around the session. That matters, doesn't it? And that needs to be, and that also leads to my next point, supervision. Is there appropriate kind of ratio from coach to participant, for example? And we've also got the idea of ethical standards. Let me just give you a base example. Let me go back to my netball, which you had here. One of the ethical standards we might have as a netball coach is warm the team up, warm the players up. That is a standard which might reduce the possibility of injury. We've also got environment. Environment, in many ways, is one of the simplest aspects of this. We're talking about weather conditions. We've got who is my triathlete? Kate. But go and have a look if you like. Kate is a triathlete. If she is cycling and it's a twisty course and it's been raining heavily, that's going to, of course, lead to more likelihood of falls. I talked about mountain biking. This could be triathlete biking, for example. We could be talking about temperature. We could talk about Kate again. Of course, if the temperature is in the 30 degrees Celsius plus or even 20 plus, the chances of sort of heat exhaustion is going to be far higher. What about things like playing surface? We can start to draw all of these examples towards different performers. We could be talking about human interaction. Okay, what about our opponents, for example? Are we playing against an opponent who is particularly aggressive, for example? And that could be performance. But also remember that there are spectators as well. Can spectators actually make it more likely? Now, we'll give you sort of an edge case of that. I'll stick with Kate the triathlete. What if there's a really big crowd and she turns a corner and she slips on the slippery wet road we mentioned before, and she collides into spectators on the side? Therefore, she's hitting something hard, right? People. Therefore, the chances of more severe injuries are greater. And we've also got the idea of equipment. Now, I could go on endlessly about equipment, so I'll be a little bit selective here. But what about, for example, what we might call PPE? Okay, think about personal protective equipment. We could be talking about things like mouth guards in sports like boxing or hockey, for example. We could be talking about helmets. I could talk about Kate again there on her bike, couldn't I? We could be talking about things like performance equipment. Okay, performance equipment. having the right type of cricket bat, for example. We could be talking about clothing, wearing clothing which is wicking and removes sweat away from the body. All of these are factors of equipment that influence with the likelihood of injury. What about footwear of Julie, our netball player, who wears the right footwear, so is less likely to slip? What about things like studs or studded boots for rugby, for football, for example. Now, we can go further and further and further, but what we're arguing is that these are the extrinsic factors which are likely to cause or otherwise prevent the risk of injury and influence how severe those injuries might be. Now, of course, we can take this much further, and we have many more intrinsic factors. Now, I'm going to go through these much quicker with you. It's a bit of my tea, excuse me. But I do want you to make notes as we go here. Let's start here. Number one, gender is it's within the individual. We can't change it. The gender... I'm going to rephrase that. The accepted term is gender. I'm going to talk about the sex of someone. I'm not going to get into gender politics, but I'm going to use the term sex just for now, and I'm going to repeat what I just said a moment ago. I'm going to say we can't change it. We are biologically predetermined to be biologically male or female. That has an influence. So, for example, this is where we have separation in some sports. After certain ages, we have separation of males and females in rugby, in football. That is a factor which will influence the likelihood of injury, for example. Age, which we're going to put here as intrinsic factor number 2. Notice that we've got age groups in lots of different activities. We separate. Obviously, that's to do with growth a lot of the time, isn't it? The likelihood of size and weight. We don't have children versus adults. Are there any exceptions to that? I'm just trying to think. Do we ever have that? That's what I don't think so, unless someone can tell me otherwise. We've also got the idea of young bones, which means the idea that our epiphyseal plates of our skeleton, for example, our growth plates, have not fully done their work in our childhood years. Your age, for example, quite possibly. And we've also got sort of the idea of old bones. Older bones are more likely to be fragile and be a bit brittle, osteoporosis and these sorts of conditions. What about experience as intrinsic factor number 3? How much experience has someone got? That you really experienced, let's go back to my trampoline example. What's the amount of experience someone's got, and how likelihood are they to fall off the trampoline, for example? 4, weight. Weight is a really important factor, intrinsic factor for injury. We've got the idea of weight-bearing sports. Think about someone pounding away on the treadmill, for example, and they're heavily overweight. That could have an impact on the knees. We could be talking about more mass. Someone who's heavier is more likely to have injury. Okay, now that's a massive generalization, and someone could probably challenge me on that, but I'm going to leave it there for now. 5, fitness levels. Goes without saying, really, doesn't it? But fitness levels. What about someone's... I'll give you an example of this. What about someone's level of flexibility? If someone, let me think about my examples where we had Tom, the tennis player. If he starts playing tennis and he's not very flexible to begin with, his tendency to get injured early on might be greater, for example. What about technique? What about ability? What about this one as our 6th intrinsic factor? Well, it's sort of like, it's very simple, isn't it? It's like good technique or bad technique. Do they do things accurately? Do they serve in tennis again, and cause epicondylitis in their elbow, for example, because they've got poor technique? One possibility. We can also be thinking about our 7th being nutrition and hydration. Again, very, very simple one. Are there enough calories that the person is taking on, or is it too many? Is there enough water in the diet, and is that allowing them to perform as they need to and follow the rigors that their body is being expected to follow? What about medical conditions? What if this is our 10th factor, what about someone who experiences the condition of epilepsy, for example, or diabetes? We're going to talk about some of these conditions later on. Do these have an influence on someone's participation? And then we can go right to the end of this, where we can look at our 11th factor. What about sleep? Sleep, of course, if we have a lack of sleep, this can lead to poor decisions, lack of concentration, might make mistakes in our performance, have collisions, maybe not compete as well. Imagine if that's a combat sport, that could be really serious, right? And what about, just to finish this off, folks, what about if I go to my 12th intrinsic factor? What about previous injuries? Something like you think about someone who's returning from any injury. You might have had a broken bone in your life. Maybe you've got one right now, for example. Right, returning from that. My daughter's 16, my younger daughter's 16, and her best friend is just had her second ACL reconstruction. A really good footballer, and she's, that's a tough thing. That's going to be something that when she returns to her football, it's going to take her a little bit of time, isn't it, to be really confident that that's not going to reoccur. So those are the intrinsic factors. Again, notice how I'm trying to link them to different performance at all times. Now, one of the things I want to talk to you about is the reasons for regression. And this comes under a section, or it's part of a section we might consider like psychological factors. It's sort of things that we can consider that are perhaps causing it. Now, we're basically saying that aggression can be related to injury, aren't we? That's what we're saying. And we're saying, right, why do performers become aggressive at times? And this is what we're saying. Basically, level of performance. If it is kind of high level, if we're saying elite performers, if it's what I would describe as hyper competitive, the chances of aggression are greater. Why? Because there is more on the outcome. The outcome really matters. It really matters. Therefore, the level of performance can sort of predicate or predict the possibility of aggression within performance. We also find it's quite common that retaliation, getting one's own back. What we mean by this is that if someone has a little dig at you, you might be more likely to have a little dig back. We all do this to an extent, don't we, in our lives? Think about your siblings. If you got them, you're pretty likely to retaliate at times, I would imagine, especially at your age. But we find that in sport, it's normal. It's often a sort of what we might call a tit for tat kind of idea of aggression. Someone does it to me, I always think about the handbag footballers who started shoving each other. I just realised handbags is sort of a sexist term, isn't it? Forgive me. But you know what I mean, that kind of shoving. Someone shoves you, you shove them back kind of thing. We see that a lot in sport. This one I think is a really important one. Pressures to win. Where do those pressures come from? Do they come from a coach? Do they come from oneself? Do they come from the situation, the need to win? All of these factors can cause pressure, and that pressure can emerge from performers in the form of aggression. Now, obviously, I've specifically said here where that pressure could come from coaches. That's a really interesting one to perceive. Different coaches have different interpretations of the role of aggression in sport. Often aggression is seen as really, really positive in sort of contact sports, football, rugby, this sort of thing. Whereas smashing your racket in tennis, Tom was our example earlier, it's not seen as appropriate, right? What about Julie, our netballer, showing aggression and shoving an opponent? It's really quite unusual in netball. It does happen, but it's really, really unusual. Tea again. Another reason, I often find this is an excuse that people will give. They will often sort of justify their aggression by saying, well, the referee got it wrong, or the ball was in when it was called out, or it was a goal, it wasn't, yes, it was a try, it wasn't, etc., etc. People often use decisions of officials to justify. I find that's quite a big excuse, but it can sort of trigger people, right? And finally, I think this one's a really interesting. PEDs, or performance-enhancing drugs. Think about the idea of what we call roid rage, as in steroid rage. The idea that aggression is often linked with sort of personality characteristic changes when individuals are taking performance-enhancing drugs. Let's use the example of steroids. So these are our reasons for aggression, folks. Now let's keep this going. I've now given myself gas. I'm so sorry. I'm going to pause. There we go. Now then, warm up, just the components to begin with, then we'll look at sort of like the impact of this. So remember, we have this phasing or predictive. And by the way, you can challenge this. There's loads of different examples of how warm-ups can be done, but we're going to argue that an individual is likely, not always, to do some kind of pulse raising. Think about something like a jog progressing to running is a classic example. You sometimes cross pitch or court or whatever, sidestep. We're going to likely then to do some mobility work. Think about our stretching. Think about those stretches. Obviously, could be static in their nature. We're then going to progress that onto dynamic stretching. Remember, dynamic means with movement. This could be arm circles, this could be lunges. That's where we tend to sort of stretch through the range of movement of the muscle and the joint, but we do that obviously with movement occurring, whereas our static stretches, our mobility exercises, might be more static. And then we go into skill rehearsal, and this is specific, folks. And what we mean by this is you want to be working on the things that actually go about informing your performance. So think about we've got Tom, our recreational tennis player. He's likely to go through some ground strokes, some volleys, some smashes, some serves. That gets him better prepared to go into the actual performance. Whereas Julie, who's our netball player, maybe if she's a GS or a GA, she might be doing some shooting practice. She might be doing some high catches and low catches into the D from a centre, for example. That might be the kind of work that they're doing. Now, where I really want to go with this, folks, is to start to talk about the benefits of this warm-up. Okay, and the first batch of benefits we're going to look at, folks, is we're going to look at the physiological benefits. Now, just remind yourself, this is what we call the physical benefits, or those things that are occurring to the body. We're going to look at the mind in a second in the psychological sense. So what happens? Well, first of all, guys, muscle temperature goes up. This matters, and it matters. I can't remember. Here we go. It matters because pliability of things increases. Now, you might not be sure what pliability means, okay? But pliability, think about your younger years when you did a bit of Play-Doh or whatever it's called, and you get it and it's cold and it doesn't move very much, and then you warm it up with your hands and it gets all kind of stretchy. That's pliability. That's the same with your muscles, with your ligaments, with your tendons. As they get warmer, they tend to become a little more kind of loose and malleable. Okay, and that's what we're talking about. We also have an increase in heart rate. This is all about delivery and return. Okay, now if you think that your blood is carrying numerous nutrients, this could be for things like glucose, amino acids, but it's also things like it's carrying oxygen to the muscles that are working, it's carrying carbon dioxide and the derivatives, or the things that break down from lactic acid, for example, back away. It's about delivery of nutrients and return of those waste products, and that's why heart rate is important in that sense. As you notice here, we get better flexibility of our muscles and our joints. Our joints go through greater range. There's my little arm that go through greater range of motion because we're warmed up. Of course, that temperature is a big factor. What have I drawn there? Pliability of our ligaments and tendons, I've mentioned already, because of that warmth. We get an increase in blood flow. Just mentioned that oxygen to the muscles. Remember, aerobic exercise or aerobic energy release happens in the presence of oxygen. Okay, so delivering lots or more of oxygenated blood, blood carrying O2, molecular oxygen, allows us to do more work aerobically. This is a positive thing, because the more work we do aerobically, the higher intensity we can work aerobically, the less we need to use our anaerobic systems, the less we're likely to fatigue. And of course, we also get an increase in the speed of muscle contraction. There's actually numerous reasons for this. First of all, the muscle is more pliable and can actually contract faster. But the other reason, we even get faster nerve transmission as a result of a warm-up. Your little wires connecting your brain nut, your computer up in your top, to your muscles. Actually, the nerves, the wires, in essence, they actually transmit faster. Okay, so this is a really interesting one. Now, it's only a tiny difference, but by warming up our kind of the neural side of our performance, that kind of our neural side gets a little bit more efficient, quicker. We also get improved, better coordination. Okay, so think about what you know about coordination, that sort of combination of movements. We get better coordination as a result of a warm-up as well. So lots of reasons then we can apply those to different performance. Now, I also want to have a look at the psychological benefits of a warm-up. Now, of course, these relate to the mind by definition, whereas they were physiological, physical ones. What happens? We get better concentration, focus. We feel more motivated. We feel more confident. This one's so important. You'll have been in this situation. You don't warm up. You don't feel ready. And that's going to decrease confidence. Now, I could get into self-efficacy and specific confidence in the situation. But anyway, we'll use a general term there, increasing confidence. We also can experience or undertake mental rehearsal during our warm-up. We can do mental rehearsal during the warm-up itself. Coaches will often bring performance to this, for example. And we can get our arousal levels to the right limits. Okay, so maybe this is the optimal point of arousal here, optimal point. We're trying to use the warm-up to get us to that optimal point. Just remember, if we go past our optimal point of arousal, this is where our performance tends to decrease. So we're not trying to get our arousal as high as possible. We're trying to get it to the right point and then control. Now, I'm not going to get into arousal, the reticular activating system, exactly what arousal is. We do that in other courses. We do that in other experiences in PE. But if we just consider it to be the drive to succeed, okay, and that drive can sort of be directed appropriately or inappropriately, it's actually important to get that arousal level right, and warm-ups help a lot with that. Okay, I've got to change canvas. That actually might be half time. Someone will give me a wave and let me know. One of the largest sections of the course is the actual types of injuries, and I'm looking here particularly like acute injuries. Okay, so one of our types of acute injuries is skin damage. There's lots of other things like sprains, strains. Obviously, look at those as well. Think about things like fractures, dislocations, head injuries. But I want to look at skin damage. I effectively, folks, what I've done here is let me go to the right layer. I want to look at 4 different types. So let me introduce you. First of all, there are abrasions and grazes. When we talk about abrasions, these are things that kind of like they're rubbing or they're scraping injuries. You'll be really familiar with grazes. They're quite unpleasant. They're almost like burns, really, aren't they? We also experience contusions, which are bruises, effectively bleeds under the skin. We talk about blisters, of course, which is caused by like footwear or ill-fitting footwear rubbing. And we also get things like cuts and lacerations, actually the skin breaking. So let's just go through this. I'll go through them fully now. So with our abrasions, our grazes, our sort of scraping injuries, how do we get them? We tend to get them in things like falls. Think about things like especially older astro pitches, for example, where not so much your 3Gs and your 4Gs anymore, but your old school kind of sand-based astros sand can still be a good surface, to be honest. But anyway, those can. How do we treat that? We stop it. We often give it a little clean, and we'll often place some kind of dressing or plaster over it. What about a bruise? Well, it's caused by some kind of impact. Think about like a dead leg, for example. Think about some kind of collision between people. How do we treat it? We rest it. You can also argue that ice is kind of useful here, so think about the Price method. Blisters, if I can put on here, if we put not just footwear but ill-fitting footwear, can obviously be other parts of the body as well, we may well get sort of blisters on our heels. That's a classic thing about the new shoe situation or new football boots, that type of thing. How do we make it better? We expose it to the air, so we want the air to get to it and allow it to heal. And cuts and lacerations, they can be caused by things like jewellery. Think about Julie, our netball player, if her opponent wears, a wedding ring or something like that, and when they go to catch the ball, it scrapes against Julie's hand, it might cut her hand, that sort of thing, right? What do we do is we wash the cuts, we obviously apply stitches. That would be done by a medical professional, and we allow it to heal. We'll often cover as well. Plaster is a nice one to add into that. So nothing really spectacular, but just make sure you can distinguish between these different ones. It's quite possible you could be asked about one of those in particular, but those are some nice ones for you to make sure that you can cover. Now, I want to talk about epicondylitis. What a word that is, folks, okay? Epicondylitis. Now, first of all, I just want to introduce you to the idea of what we would call lateral and medial. So lateral epicondylitis, lateral always means on the outside. Okay, so when we talk about lateral epicondylitis, and by the way, we're now into chronic injuries. I should have stressed this earlier. We're now into chronic injuries at this point in examples. With lateral, what we're saying is the pain is on the outside of the elbow. And of course, in this case, we refer to this as tennis elbow, pain on the outside of the elbow. What's the cause? It's repetitive elbow flexion, which of course means it's coming with elbow extension by definition. And we might experience it because of poor technique. So think about our Tom tennis player constantly serving, but with poor technique, that could cause outside of the elbow pain, lateral epicondylitis. How do we treat it? You really want to be using the Price method. So we've got here ice and rest is the way that we do that. This is a chronic injury, will not go away unless the technique changes and we rest it properly. Now, we've got the same principle, but this time medial. Medial always means on the inside. And I should be clear here, we don't mean on the inside of the body like in your guts or, in your blood. No, on the inside. If you look at your elbow, you'll have one sort of side of it, which is on the inside of your arm, more on the outside. That's what we mean by this, right? So medial's on the inside, and we call this golfer's elbow. Why? Because we're getting repetitive elbow extension, again, which by definition has to come with flexion, because if you're going to straighten it, you have to bend it again. But again, it's caused by poor technique. How do we treat it? We treat it with price, and we call it golfer's elbow. Now, I should be clear, because they're called tennis elbow and golfer's elbow, does not mean they only happen in those sports. It's just those are sort of like the colloquial terms we apply to these. You could quite easily get golfer's elbow from tennis, for example, which is bloody irritating, but nevertheless, it's caused specifically by either extension, straightening of the elbow, or flexion, bending of the elbow. And of course, those things come in combination. By the way, I also know one person, always injured by the way, who has both of these at the same time. Now, I say injured a lot, always making excuses, you know you are. And that also PE teacher is often experiencing both of these. Anyway, I believe him, really. Let's go down here. Now, we also want to have a look at emergency action plans. I bet you loved this lesson, didn't you, when you covered this? I bet you absolutely couldn't believe your luck. Emergency action plans. A couple of things I want to cover here. I want to make sure that you can distinguish between personnel, which of course relates to people. So here's our why is that not working? Personnel. I want to make sure you can distinguish between communication and equipment. So examples. So with personnel, first of all, we are talking about having people available who are first aiders or first aid or emergency responder training. I've done first aid training my whole life. I'm not that good at it, but I have done a lot of first aid, and you'll find, for example, PE teachers, coaches, and sports administrators, they will often be first aiders sort of by definition. But also, this one's really important. Clubs, let's say voluntary clubs, for example, they also need what's called a safeguarding officer. A safeguarding officer is not likely, could be the same person, but not likely to be the person that gives first aid. Someone falls over and bruises their knee. No, this person is about making sure the environment as a whole is safe, often for young people to participate in. This is safe from any kind of threat. That could be a physical threat such as injury, but of course it could be a threat of inappropriate behaviour by an adult. I don't want to get into groiness, all that horrible stuff, but you know what I'm talking about. The safeguarding officer is there to make sure the environment as a whole is safe, often for young people to participate without the threat of other people or negative things occurring. Now then, I also want to talk to you about communication. With communication, this one seems a bit daft these days, but believe it or not, we didn't always have phones, folks. We also need people to have access to a telephone. Now, I would imagine these days it's very rare for a coach to do a session without a phone nearby. But trust me, it used to be the case. So access to a telephone is really, really important because, things can go wrong. But the other one is the idea of emergency numbers. And these are often held in something like a first aid kit, or there's some kind of card or page on a website where someone can go to and go and find the relevant numbers that someone needs. Now, obviously, these could be things like 999. That's kind of an obvious one in the UK. But these could also be people like, can I quickly get hold of the first aider who's on site because someone's fallen over and twisted their ankle? We can also be thinking here sometimes about the idea of walkie-talkies or some kind of instant communication device. This is quite common at sporting events, for example, so everyone within a team can hear essential communication as things progress. Now also we've got the idea of emergency equipment here, folks. Now there's really obvious things like a first aid kit needs to be part of an emergency action plan. Of course, we need to make sure there's access to that, but we could be talking about things. I've only seen this used sometimes, but access to wheelchair, to stretcher. Again, there's always a balance here. That's not a joke. But what I was going to say there's always a balance. Quite often, if someone needs a stretcher, non-medical people probably shouldn't move them unless there's a real strong need to do that, right? But a stretcher is a good example. We could be talking about a medical bed that's in a clubhouse or something like that. We should have another one here, hard word to spell, but also I said that, I literally spelled it wrong. Hang on a minute. I was wanting to write the word defibrillator. One of those things that hopefully you'll never need to use, but will potentially restart someone's heart should they suffer SCA for a sudden cardiac arrest, for example. I have actually used that on one occasion with an individual. I won't go into details, it was horrible. But those are strategically positioned around our society, and you'll often find them in sports clubs. Now then, one of our responses is the SALTAPS method, okay? And SALTAPS, of course, is this kind of acronym, and we're going to make sure we understand each of this stage. Can I just stress to you before we get into this is how we respond to injuries at times. Can I stress to you that depending on what you read, the S bit is sometimes referred to as stop. Okay, so just bear that in mind. You might read something, oh, hang on a minute, I'm sure it was C, or I'm sure it was stop, or the other way around. These are interchangeable. All the other ones kind of stay the same, but depending on what you read, you will see both of those, so don't freak out too much. If you want to be tactical in your answer, you make sure you put C, but you might want to include stop, just in case. So what is this cell taps thing? Well, first of all, we need to be paying attention. Why? Because we need to see the injury occur when it occurs in, for example, let's go for our gymnastics floor routine with Laura. Therefore, we stop the activity. We're paying attention as the coach, the trainer. We see it. We stop the activity. What do we do next? We use A. We ask the participant what happened. Now, this is a very, very obvious thing to say. What happened? Why are you on the floor? Why are you screaming? That sounds a bit ridiculous. But you know what happened? It might be the detail. I twisted my ankle. I landed heavily. I ran into a wall. This is not funny, but it sort of is when I'm saying this at this time of day. But anyway, now we also, with this one, with ask, the other thing you can do here is you can also get a history. Okay, so the other thing you can ask about is, let me put it in here, injury history. Has this happened before? That's actually a useful question. And also, you can be looking if anyone else saw. Did anyone else see? Because it might be that you didn't see and someone else can give you information on that. Now then, our L is look. And we're specifically talking about at the site, at the injury. Is there any obvious sign of injury, such as disfiguration, blood, swelling? These things will help you obviously assess what's going on. Now, T is touch. Now, this is where we get into slightly challenging territory, because you want to be careful here. If the with permission, will the injured performer allow you to touch the injured area? Okay, that's sort of like placing hands on. How's this? Does that hurt? You know, the sorts of things that can happen. Now, we then go into A, active. I want to be really specific here. Can they, the injured person, can they move the injured area? So without you doing anything, touching them, moving them, can they move the injured area by themselves? That's them actively responding. Once that does or doesn't happen, typically, because it would, you know, obviously if they can't do that, you're going to be really cautious at going and moving it for them. But let's say they can move it a little bit, you might go into sort of passive movement. And what we do with this is that you, as the responder, you potentially would move the area, and this is the important part, through full, that's an F, range of movement. Okay, so we then sort of help, bend the knee and straighten the knee backwards and forwards through its full range of movement. And then finally, guys, in order before us to get them back into performance and get back on with what they're doing, we would look at S, which is strength. And what we do here is we want them to move against resistance. Okay, so we want them to move against resistance. So they'll push against a force that you provide, right? Show me you can push back against me. And at that point, you can be pretty confident, okay, this person can go back and can compete again. Obviously, if they, air quotes, fail, not that it's that kind of test, but if they fail these stages, then that's where you're going to sort of look for external support, first aid or beyond, okay? So that's where you obviously want, because if the person, for example, can't move that injured area, is completely immobilized, then that's a very, very clear sign that support is needed to be found. So don't take too many risks with that. Okay, just a super quick break, folks. One sec. Okay, good. Now, I actually want to just spend a moment here actually explaining asthma attacks to you, okay? So just to make sure that you have a sort of a rudimentary understanding of how asthma attacks actually happen. But if I can just say it like this, you could even skip this bit if you're watching on demand, but that is in essence here, this is the essential knowledge, okay? So if you don't want to know, I don't care how it actually happens, I just want the information, that's the information there, and I'll come to that in a second, but I just want you to understand how this happens. This sort of blue thing here, this whole kind of, this thing here, this whole sort of space, this is what we'd call a bronchiole. Okay, well, this is a bronchiole, and a bronchiole is one of the smaller kind of passageways in the deeper part of the lung before it gets into those little air pockets at the very end. So it's one of those sort of smaller tubes, for want of a better response. But what I want you to notice is that it's surrounded by muscle. This thing here is smooth muscle, and because a certain allergen, notice for example we could be talking about pollution, smoke, animals, chemicals, because these allergens are within the space inside the bronchiole, what happens is they get detected by what we call alpha detect. That bit doesn't matter, but they get detected, look just here, and that causes a reaction. And what it does is it causes a chemical called histamine, and you might have heard of antihistamines, like anti sort of swelling things, but histamine is now released into the muscle here. And what then happens is this muscle then sort of closes down this space. It closes down this space. It closes down this space. It also triggers the pollution of what we call mucus. And you'll notice that we've got mucus lining the walls here of the bronchiole, and more mucus will be produced. And the main point I want to notice is, notice how big this space is before an asthma attack and how little it is after an asthma attack. And that space is called the lumen, by the way. So in essence, what's happening is our airways constrict. Now this little beta detector is also important here, folks, because this is ultimately when we take our inhaler, for example. These are these little things here and here and here and here. These are the detectors which will sort of pick up on the reliever inhaler, and they'll actually cause a relaxation of that muscle and a less production. But that's what's happening during an asthma attack. Those airways are constricting. Now you can see why someone would drag their breath in like that. Now, I forgive if you have asthma. It's serious, by the way. It's not a funny thing, and I'm not trying to be funny. My elder daughter Anna suffered very severely, hospitalised 4 different times with asthma, 2 occasions for a week each. So this is not something I personally take lightly, but this is actually what's happening in those situations. Anyway, what are the triggers? Well, I've mentioned already pollution, smoke, animals, chemicals, but also we have something called EIA, exercise-induced asthma. This is particularly prevalent when young people are teenagers. Why do we say that? Because their bodies are changing rapidly, okay, especially through puberty and maturation processes. Teenagers experience EIA quite more than in other areas of life because our body's changing more rapidly, and exercise, especially on really cold days, can trigger asthma as well. Well, the symptoms: coughing, wheezing, whistling, my horrible kind of impersonation, again, of shortness of breath. We get tightness in that chest and we feel like I can't breathe. It's not pleasant. We get reduced intake of air. We get reduced gaseous exchange, so less oxygen going into the blood, less CO2 coming out of the blood, and therefore we get less oxygen saturation. We actually call this the SATS reading. Now, I don't know if you know this, but your blood travels around your body at very near 100% saturation with oxygen. Someone who's having an asthma attack can drop down to 70%. Now, this is where someone's in real trouble. This is threat to life stuff. Okay, so this could actually be a really, really serious thing. How do we treat it? One of the things is reassurance, help the person to calm down, because stress and arousal will actually cause it to be worse. We can use, of course, our reliever inhalers, which is the blue one, and our nebulizers. Don't forget as well, you've got blue inhalers. This is for relief. And you've got to see if I can choose a browner colour. Hang on a minute. Sort of brown. And then you've got brown. This is what we call the preventer inhaler. Okay, so we use these on a regular basis. We use these when we're having problems. Okay, beautiful. Now, diabetes, lots and lots of information here. Again, I could almost just say to you, learn that table, folks, and you'll do pretty well. Can I just differentiate for you, please, guys? Can I just differentiate that we are talking about type 1 diabetes, which is something that often will occur in younger life. It is believed to be genetically predisposed. And type 2 diabetes, which is what we might call lifestyle diabetes. These are different things. But in both cases, we have either got an underperforming, poorly performing, or not at all performing pancreas that is not releasing pancreatic fluids, including insulin, through the pancreatic duct into, you should be doing GCSE biology as well, I'm assuming, into, you guys know, into the duodenum or the duodenum, the first stage of the small intestine. You guys know there's a lot of sort of digestion happening there, don't you? That chemical digestion. And our pancreas is not performing that role. So type 1 diabetes, what is it? Normally develops through childhood. And it's not impacted by lifestyle, whereas type 2, it's normally later in life, and it's caused by poor diet and sedentary or non-active lifestyle. What are the causes? Well, diabetic's genetic. We've got insufficient pancreas or non-functioning pancreas, and the body doesn't produce insulin. Insulin is a chemical which helps to manage, often, well, it will reduce blood glucose levels. Okay, now I'm not going to get into the mechanics of that. I've got other videos on that if you're interested. Whereas type 2, the body no longer produces enough insulin, and the insulin doesn't work properly. It's not having the effect it has, and we've kind of done that to ourselves to a degree. Symptoms. In both cases, thirst, urination, tiredness. This one's an interesting. Weight loss. This is what we might call an acute symptom, especially with type 1s. This will happen in the early stages. We might even find that cuts don't heal well long term, and it can lead to dehydration. How do we treat it? Insulin injections, sometimes taken orally, especially with type 2. Glucose, if blood sugar drops very low. So often it's not so much we want insulin to make us feel better, but if our glucose levels drop, we need to eat something rapidly. Lifestyle changes, diet, exercise. That's what diabetes is treated like. Now, again, just put a personal sort of twist on this. My little brother, he's in his 40s now, bless him, but he's a type 1 diabetic, and he developed diabetes at the age of 7, I think it was. So diabetes was part of our household, and this is very familiar to us. Now, I mean, geez, this one's a really relevant conversation at the moment. I believe the most recent example of SCA was Tom Lockyer, footballer at Luton Town, actually Premier League football captain. I want to be very cautious about SCA because I've been reading heavily about this condition at the moment and its association to recent... I'm not going to go into it. But SCA is a sudden cardiac arrest. Let me define it. It's a medical emergency normally caused by a sudden loss of blood flow to the heart. Okay, so sudden cardiac arrest. And remind yourself, cardiac arrest is the heart stopping. Okay, the heart actually failing and stopping. Now, I read an article recently which reported that in the US military, 958% increase in this condition in military-age males. Anyway, in the last 3 years, let's leave that. Anyway, let's go to it. What causes it? Underlying genetic heart conditions, intense physical activity, trauma, coronary heart disease, blood clot. These will cause a sudden cardiac arrest, okay? What are the symptoms? The person will fall unconscious. They will experience breathing difficulties, may experience chest pain and pain down the arms. This is preceding. They may experience sort of dizziness and lightheadedness. They may experience sweating. And one of the things that comes before a heart failure is kind of a feeling of, oh my God, something really terrible is about to happen. This sort of feel of, oh, dread. I've never experienced it, so I'm kind of making it up. Now, how do we address it? Defibrillator, as I poorly spelled earlier. Lifestyle changes, better diet, more exercise. Aspirin is a blood thinner. Okay, so it can actually help the blood flow a little bit better. Medicines to dissolve blood clots. You guys are probably studying things like statins in your biology course and so on, and surgery. Think about things such as stents, and this kind of stuff can be used to help in these situations, but obviously that will vary from person to person. Now, where are we? Final thing for today, heat exhaustion. Obviously we've got exercising in the cold as well. Heat exhaustion. Let's look at the symptoms. If someone's experiencing heat exhaustion, what do we see? Well, we will get excessive sweating. Gordon Bennett, that's most of my life. Excessive sweating, pale, clammy skin. Oddly, people will go pale if they're experiencing heat exhaustion. Headaches, dizziness, extreme thirst, nausea. Their pulse will increase rapidly. Of course, that's trying to do its work. Rapid breathing and cramps in the legs and sometimes in the stomach, which is an interesting one. How do we treat it? We must cool that person down. We must get ice or ice towel onto the skin. We want to get the feet above the head by lying the person down. Water. Stay with them, and we need to cool them down within 30 minutes. Otherwise, this person's going to be in trouble. So we should get them cooled down in 30 minutes. Okay, so the effect should be manageable. Now, will the headache go immediately? No, that could last actually days, and this is not a pleasant experience. And you've probably all had aspects of this at some point in your life, but this is how we treat that condition. Now, folks, we've gone through a monstrous amount of information there. You probably will need to go over it a couple of times. Make sure, put it this way, folks, if you can get the language that I've covered in this session into your exam paper, you're going to score a lot of marks, assuming it's in context. And I hope that's exactly what you do. What a session. Now, folks,
I've just been told we don't have any questions in, so I'm going to wrap up nice and tightly and quickly. Thank you so much for being part of the session. Do remember to drop a like and a subscribe if you're able to onto the channel. We really, really appreciate it. And all that being understood, I'm going to wish you a great evening. I've been told dinner's ready in my particular circumstance, so I'm going to go and get on with that. Thank you once again. Have a brilliant, brilliant evening.